Good afternoon. Thank you very much, first Professor, for inviting me. So I will continue with this case presentation. It's a female patient that presented last week to our outpatient department in rheumatology with a persistent rash, arthralgia, with red eyes, with headache, persistent hearing loss, and general symptoms and signs with fever and asthenia. The symptoms got worsened during the last 6 months, and these were not influenced by symptomatic treatment like NSAIDs or painkillers, neither by corticosteroids, she is being on low-dose prednisone, or by current immunosuppressor drugs, which I will describe in a few moments. So the history, the onset of the disease was at 3 weeks old, with fever, no specific pattern, sometimes it's called exposure, later on by stress, but we don't have much information from the previous years. And with this rash, urticaria-like rash over the trunk, lower limbs and upper limbs, it was not non-itchy rash. Over the years, she presented with red eyes, bilateral, diagnosed with conjunctivitis, with progressive hearing loss, diagnosed with sensory neural hearing loss since childhood, abdominal pain, episodic, and with joint involvement, especially lower limbs, joint arthritis with the bilateral ankle arthritis, a non-erosive arthritis. Biological with inflammatory markers, but only during the attacks of fever and painful joints. She was tested negative for rheumatoid factor, anti-CCP antibodies. Over the years, in other departments, she was diagnosed with urticaria vasculitis, hypocomplementic vasculitis, or lupus, but we don't have, just from the history, we do not have the medical records, and including rheumatoid arthritis because of the persistent joint inflammation and inflammatory syndrome. And she was treated with corticosteroids for long-term corticosteroids on low dose and medium dose according to the symptoms, especially joint symptoms and inflammatory markers of inflammation with partial response, the joint manifestations, biological inflammation, some decreased with treatment. At 60 years old, she was tested, genetic tested. 7 genes were tested. These genes are mentioned here on the slide. Genes for FMF, for TRAPS, HIDS, for Blau syndrome, for DADA2, and the mutation that was found, it was the NLRP3 gene 1 mutation that is underlined in this table. This is the report from the pediatric department in Budapest, and basically it's written that she has this mutation, 1 gene mutation, and this is the other were negative, and the patient clinical data and the results of the current genetic testing supports the diagnosis of CAPS, and that the anti-IL-1 treatment should be considered to prevent the recurrence of acute episodes and to control inflammatory parameters. But she was not put on that medication because it was not available in Romania at the time. The first visit was after 12 more years, so at 28 years old, she presented for the first time in our department with hearing loss, with some skeletal abnormalities that we may see with frontal bossing, with red eyes, persistent red eyes, and abdominal pain, and a periodic fever around 38 Celsius for 2-3 days. The urticarial-like rash was also present, as we can see in these images, and the arthralgia and the joint swelling, especially the ankles, non-symmetric, that you can see here, was also present, with inflammatory markers of inflammation, with high CRP, high ESR, negative for rheumatoid factor and CCP negative. In these clinical circumstances, and also with the genetic testing that we had, the diagnosis of CAPS and Muckle-Wells syndrome was established. Of course, the differential diagnosis includes all the other conditions of periodic fever, but not only those. So professors mentioned before me the differential diagnosis, and includes also autoimmune diseases or other conditions. But in this case, the diagnosis was established. And she was, of course, treated with, at the time, with the prednisone, low or medium dose prednisone, but also with DMARDs, and methotrexate was started, 20 milligrams per week. And due to all these clinical parameters and paraclinical inflammation and clinical conditions, so she was put on TNF inhibitor since September 2017 on etanercept standard dose. No IL-1 inhibitors available in Romania at that time. So she had the follow-up visits revealed a favorable response in terms of joint pain, inflammation, but the intermittent rash, conjunctivitis, intermittent fever, and headache persisted during these years. Then she planned a pregnancy. Of course, she was giving, the informed consent, explained her the risks about the disease, and she was switched to azathioprine. She was still on etanercept, and at 32 years old, she gave birth to a boy, and after 4 hours, the boy developed this rash that you can see in these images, so 4 hours after birth. Given the clinical context, the positive family history, the patient told us that the boy was diagnosed with Chinka syndrome, and he is currently treated with anakinra. He's less than 2 years of age right now, so he's not 2 years yet, so he's treated with anakinra daily. The baby was also tested. I just named the gene here, so positive for NLRP3, pathogenic, but I saw the report, and there were also other genes with unknown significance present in the report. I didn't know how to make an interpretation of those, and there were too many genes. And back to patient's last visit. Now she presents with clinical features of Cushing syndrome. She took prednisone over the last 6 months due to her symptoms that were worsened, especially the rash, the headache, the arthralgia, and the joint deformity that you can see in this image, especially the ankle, the unilateral, and fever and fatigue. She continued with the etanercept and azathioprine and colchicine, but with no obvious effect. From the paraclinical point of view, she has still inflammatory markers of inflammation, with ESR increased, with CRP increased, leukocytosis 13,000 with neutrophilia, with no other abnormalities, with no renal involvement, with no no proteinuria. So given the clinical context with active disease from the cutaneous, neurologic, musculoskeletal, systemic, and lab assessment with inflammatory markers of inflammation, leukocytosis, neutrophilia with no other abnormalities, no signs of infection currently, screening for hepatitis B and C, tuberculosis negative, we have the criteria for initiating the anti-IL-1 blocking agents, and patient has given the informed consent for canakinumab, starting canakinumab, and with a follow-up after 7 days according to the protocol with treatment dose reevaluation according to the clinical therapeutic response. She's also was scheduled for X-rays and musculoskeletal ultrasound for especially ankles, and other imaging, cerebral MRI in case of persistence of headache. I will not go through all these clinical characteristics of CAPS because these were presented very well before me. But probably this patient has this Muckle Wells, but I would just want to underline a few aspects regarding the frequent mutations, because there are some frequent mutations that were already described, but sometimes there are patients that have an overlap phenotype, let's say, overlap between the three CAPS syndromes, and this mutation that I found in the report, D303N mutation, it seems that it's an overlap between Muckle Wells and Chinka syndrome. There are patients at high risk for a severe disease activity, as Laura mentioned before me, female patients with hearing loss, with musculoskeletal symptoms, with elevated ESR, as our patient present all these features. So some genotypes are associated with a specific phenotype, but in this case, it's probably an overlap disease. This is a table that underlines the same thing, and if we look, there's an arrow indicating this mutation, D303N, which is somewhere between Muckle Wells and Chinka, and no mid. So this gene was found also in the positive in the baby. Of course, IL-1 blocker in CAPS are very effective, and it was already discussed. So in this patient, we have the indication for canakinumab. We just need a couple of more days to finalize this process with a medical prescription, and I'm very sorry that I can't have the result because she did not receive her injection yet, but hopefully next week she will. She's right now she's hospitalized with a baby for the hearing tests. So it was the visit was scheduled, so we have to wait a few days. Regarding monitoring of the disease, it's mandatory to monitor the disease, crucial to determine the disease activity and the organ damage, and the general physical examination, the audiology, ophthalmologic exam, musculoskeletal, neurologic, and lab examinations are important. And as it was already mentioned, for monitor the disease activity, the patient diaries and the disease activity score is important in terms of monitoring. What about the prognosis? The prognosis depends on the phenotype, and in this case, probably there is this overlapping, as I mentioned, between Muckle-Wells and Chinka. An early diagnosis allows the start of an effective treatment to improve the quality of life and to avoid the organ damage. The prevalence of amyloidosis varies according to the phenotype. She is a patient at risk according to the risk factors, but no indicators for amyloidosis. I'm wondering if etanercept's treatment maybe prevented this or not. Anti-IL-1 treatment improved the prognosis of these patients, and early treatment can result in reversibility, for example, hearing loss, but in this case, it's obvious too late, but there is hope for the patients. I thank you very much for the attention.